We're here today with Mike Holmes. Mike is the CEO of Boundary Waters, is that correct?
Cook Area Health Services, but we do business now as Scenic Rivers Health
Scenic
Services.
Rivers, that's it. Boundary Waters is part
It's
of your...
Boundary Waters Canoe Area. We're
Yeah.
tucked up next to the
Scenic
wilderness.
Rivers, I love that name. But Cook Area has been its name for years now, right?
Since we started in 1979.
Wow. And you cover a slightly larger area than you covered when you first began servicing, but still.
When we first started, it was we started in this community of 800 people, and we were tucked up right next to the Boundary Waters, single site, 2 physicians, 2 dentists, myself, and there were 13 of us in total. The two physicians, one just retired in December, and one retired this spring.
They both stayed with you over all these years.
They stayed with us in that site for 40 years.
Wow.
Now, I'm not the only one left from those original 13 staff members. We have a dental assistant that started with us in 1979. She took some time off to raise a family, but she's still working chairside at our dental clinic in the original community. Over the years, as health centers expanded, we expanded our sites, we added new access points, we added services. And so right now we have 6 medical clinics and 4 dental clinics in an 8,000 square mile service area. That's just slightly smaller than the state of New Jersey.
Wow.
So we're the only access points to care. There are 2 small critical access hospitals in this service area. One's 14 beds, one's 20 beds. But it's our physicians that staff them, staff the emergency room, staff our clinics, long-term care. They do long-term care rotations, and they'll still do an occasional home visit.
And what's your clinical staff looking like today? Physicians,
Right now,
PAs?
Right now, we have 13 physicians. We have 9 mid-levels, a combination of nurse practitioners and PAs. We have 8 dentists right now. We have 2 dental therapists, which is a new discipline for Minnesota. And essentially, it is a mid-level provider. And so the dental therapists will do restorations and exams. And it allows our dentists to do more complex
Which is
treatment.
probably, I think for those who want to rise to the challenge, that's a great relief to get rid of not get rid of, but to not have to focus on some of the more mundane.
Well, there's such a shortage of dentists and oral health care access in rural areas, especially in rural Minnesota. If you look at the average age of dentists, it's going to be over the age of 55, and they're winding down their practices. They can't sell their practices, and so there's all of this unmet demand, a need for care.
Yeah.
Even if you have dental insurance, and not many people have dental insurance, but for the low-income patients and for the Medicaid patients, it's impossible to find someone that will take you unless you're going to a health center. We have dental patients that are traveling 120, 130 miles one way to access care in our clinics. So the demand is there if we can staff and find enough dental providers.
Sure. And I'm sure that's true for rural areas, not only throughout Minnesota, but all across the center of the country.
The shortage of practitioners, especially in the rural areas, is just one of the challenges in the workforce. It's a challenge to find primary care workforce for our health centers, but in the rural areas, you're not only combating the patient population and the shortage numbers of primary care practitioners, but then you're trying to relocate them to geographic areas where it may not be attractive. Maybe it's attractive to the practitioner, but it might not be attractive to the families of the practitioners. And so you look at challenges with additional job opportunities and resources and things like that. Yeah. So the small communities do have an extra challenge trying to find people that will serve in those communities and provide the staffing
Yeah.
to maintain those access points.
Wow. Now, I want to roll it back a little bit here and ask you what attracted you to this career? And when you began, what were your impressions and what were your top priorities when you began your career in healthcare, with health centers?
I started in healthcare in 1977. It was early 77 in one of the small community hospitals, long before there was a critical access hospital designation, had an opening for a business manager. And I had recently returned from California. And so it was attractive enough, and I knew some of the people in the community because it's where I went to high school. And so I joined the hospital, and the hospital was running on very thin margins. In the previous 6-7 years, it had been open and closed off and on because of a lack of physicians. The community would have a physician come in, they would stay for a while, they would leave. Every time the physician left, there went the primary care access point in the clinics, there went the care for long-term care patients, and the hospital would have to close. So needless to say, the community was really concerned about trying to find a way to provide stability in an environment so that they could bring in physicians and practitioners, so just to maintain access. A health maintenance organization came into the community, brought in that first physician, the one that just retired last December, and he was fresh out of residency, and he started his practice. And he was well received by the community. Well, the HMO decided that it was not in their best interests to operate small rural practices. It just didn't meet their staff model because there wasn't significant population base. And they decided to refocus. And so they spun off and said, we're closing these primary care practices, and it was ourselves, our community. It was another community that has a health center still in Minnesota. It was Sawtooth Mountain Clinic up in Grand Marais.
Oh, sure.
And there was a third that was down towards the cities. They gave us a deadline, and the community was scrambling to try and figure out what to do because there was a second physician that had just come. This was the one that retired this past spring. And there was no stability in infrastructure. The practice structure was in flux. And there was great concern that if these two physicians left, no one else would be there to take their place. So we started looking around, and the board members and community members started looking around, and they came across something called the Rural Health Initiatives Program. This was one of the forerunner programs before they were all consolidated into the Bureau Authority.
Sure.
The original premise on the Rural Health Initiatives Program was you get 3 years worth of seed money, and then you should have a fully established private practice.
Function on your
It was
own.
3 years and out. Well, a year and a half into that Rural Health Initiatives Program, we were successful in our application, and we formed a nonprofit to start the initial center, what became Scenic Rivers. The Reagan administration came in. David Stockman came in as the director of OMB, and immediately they cut 20% out of health funding. So Minnesota at that time had 13 health center sites. We went from 13 to 5.
Wow.
And then we started that long process of clawing back and trying to regain what we had lost in that initial defunding cycle or reduction in funding cycle. But we survived it, and along with all the other organizations at the time, and then the new access points, as new federal money came along, we were able to expand the number of access points, the number of services. And so that group of 13 original people is now 140. And instead of one community in a town of 800 people, which is less population, and now it's about 650, we're now in 6 different communities with medical and dental clinics. So we've got 6 medical clinics, and we've got 4 dental clinics. Our physicians are split between our 2 main sites, which are adjacent to the hospitals, and then our other 4 medical clinics are 40 to 50 miles away from our 2 main sites. and we staff them with mid-level providers. And so we try and match the staffing to the community sizes, and knowing that transportation is such a huge issue.
Yeah.
There's no public transportation in northeastern Minnesota. It's a frontier in a remote area. It's sparsely populated. You know, the population density is 3 people per square mile. So there's no interstate. There are no interstates.
Yeah.
There's no cell phone service once you get beyond 8 miles from town. There's no internet.
Wow.
There's
It's
no cable
isolation,
television. I mean, it's a different environment. And so our whole intent was to do whatever we could to keep these access points open. Initially was the first one in Cook, and that's what we did. I mean, it was the whole point of it was to maintain primary care access. And as we grew, then we started developing other services for the community and other services through the health
Oral
centers.
health,
Oral
behavioral
health
health.
was part, interestingly enough, oral health was always a part of our initial site. But in some of the subsequent expansions, they were medical only. And we've come in after the fact now to expand oral health services in a number of our other communities, as it's much more critical now as a part of the care delivery system. And now we're in the process of adding behavioral health services and telebehavioral health services. So we're all of our sites are on a common EMR platform. We're all linked with high-speed bandwidth. We're on a common, so we're on a common EMR. But as a part of developing the bandwidth for the electronic health record, we also have now boosted the speed so we can do telehealth services. So we can have behavioral health workers in one site and maybe have a patient that's 120, 130 miles away.
And you're able to have that virtual
And it's a
consult right
face-to-face contact.
there. Yeah. You think that, not that it is the future, but it points the way to a viable future for rural healthcare?
I think
America?
it's viable in certain locations. Now, when we talk about telehealth services to a patient at home, that patient still has to have enough bandwidth for you to conduct a visit, a
Sure.
face-to-face visit. If there's no cell service, if there's no high-speed internet, it becomes really problematic to try and do a telehealth visit over dial-up. And there still is dial-up internet in some of these rural areas, or you have to deal with satellite internet, which is not much better than dial-up.
Yeah. Catch as catch can.
I live next to the main highway that goes north and south from Duluth to International Falls. I have 3 huge fiber cables that run in front of my house. I only got DSL service 2 years ago. And so that's coming in on copper. So if we're in the primary corridors and we can't get fiber to the home and we can't get high-speed bandwidth, it's going to be a limiting factor for telehealth services in some of these remote areas. So that's why we're trying to build up access points that are within our network that we've already constructed through our telephone networks and our high-speed bandwidth networks. So we've got places for patients to come to so they don't have to travel 100 miles or 120 miles. Maybe they only have to travel 20. So it's not perfect access, but it's better.
Well, boy, that's a huge relief compared to the alternatives.
The alternatives are no access.
No access to care.
So,
That's exactly right. You talked about the Reagan block grant and the threat that posed. Not long after you you really began to operate.
welcome to health center funding.
community
You're getting
health center
20%
thing, yeah.
less.
What other threats has Cook area scenic waters faced over the years?
I think when we look at threats, one of the more difficult parts of healthcare is the constant changing in reimbursements. The reimbursement systems continually change. You know, in the early days of Medicare and Medicaid, everything was a discounted fee for service.
Yeah.
Then we went to a per visit rate and cost-based systems, and then we went to a prospective payment system. And now we're kind of in between a cost-based system and a prospective payment system. And the latest iterations of payment reform now are accountable care organizations and at-risk payments for the total cost of care, and trying to create different incentives. And I think when these payment systems change and we see a trend to vertical integration and large health systems that are controlling the market, it presents a threat to the small players in the system or the small providers. And the vertically integrated health systems are not necessarily all that concerned about how people access care in these small population bases. They're more concerned about how many members do they have in their group, what's their total cost payments that's coming in on a capitation basis, what are their incentives, and how do they maintain integrity within that system. And one of my biggest concerns for small health centers and for rural health centers too has been unintended consequences, where you have all of these pressures for cost containment and better outcomes and better use of resources, that when they change systems and they don't think what happens to the small entities, we get caught up in trying to adjust to something that we don't have a lot of depth of resources to adapt to. And so that gives me sleepless nights.
That is a challenge now and for the future. It certainly is. Although I think our poor powers notwithstanding, it's inexorably moving forward. And
there's certainly no question that more change is coming to the system. When you look at how much healthcare consumes out of the gross national product and how many tax dollars that we're spending on a national level for health services, that percentage is reaching maximum capacity for the system to bear. And there are other needs that the government has to attend to, federal and state services need to attend to. We're not going to see a time when 50% or 60% of the tax revenues are spent on healthcare. It's just not sustainable. So that means there has to be pressures within the system to reduce that cost of care. And we have an aging population. And
so demand is going this way, and the pressure on the resources.
We have an increase in the number of patients just because of population growth. We have an aging population, which hits the rural areas harder than urban areas, because if you look at the demographics, it's a much higher percentage of Medicare age population in the rural areas.
Oh yes.
And they're they have the least ability to travel. So the care has to be delivered closer to home for them, but there's such cost pressures in the system, the question is whether it's sustainable and whether some of these small access points are sustainable. When I started in the late 70s into healthcare, since that point of time to today, over 2,000 small rural hospitals have closed. And that trend is not decreasing. That trend is accelerating, where the hospitals are not sustainable according to corporate medicine, let's say, or the large systems. They're trying to find, the systems are trying to deliver economies of scale, and so their choices are to close rural facilities, rural hospitals, because there's potential cost savings. But it's done at a risk to the patient communities and the people that really count on accessing care. And to a certain extent, we have the same issue with health centers, that there has to be certain economies of scale. We have cost pressures that if you are a small health center, it's extremely difficult to put in your own electronic health record. So you've got to do it through networks, and you've got to do it in cooperation with other entities of like mind. And certainly health center models have had really good results of shared EMR platforms and making EMRs available to health centers through a network format.
That's going to be crucial for the future as well. Not just IT, but really actually care delivery. I
Here,
think.
the whole point now is to focus on improving clinical outcomes.
Yeah.
And with improved clinical outcomes, we should be able to sustain or at least lessen the increases in cost of care. So if we can spend money wisely up front with primary care and better care management, patient case management,
Yeah.
long term, that should save us through reductions in emergency room use,
Sure.
reductions in hospital admissions and readmissions. But it takes those electronic platforms to track what's happening with patients and creating a vehicle that you can do data extraction when you're looking at case management for certain disease processes and certain care coordination that you want to do. If you don't have the data in a searchable system, you're not going to be able to be effective in managing care and providing that care coordination, doing the recalls for patients when they need to come back to manage their diabetes or hypertension.
Yeah.
But that's where the cost savings are. And so you've got to be able to have the systems in place to do that.
Robust primary care, good information technology, care management techniques that emphasize prevention and wellness. We know all the markers of the roadmap to better health and reduce spending.
True.
So why haven't policymakers, decision makers, and the poobahs who are responsible for managing healthcare recognize that and move toward that, in whether it's in payment systems or in structuring healthcare for the future?
That's a good question, because as long as I've been involved with healthcare, we've been under healthcare reform.
Yeah.
Everybody has a great idea of this is the new model for healthcare that's going to have all of these grand results. But the devil is always in the details, and any type of payment reform that comes into place, some people may think they're winning, some people think they may be losing, and so they may work to block some of those changes in the system. And so it's a long, slow process to try and get reform.
Yeah.
How we trained providers in the early days, where it was more of a production model, where you tried to see as many patients as you could, and that will generate certain income levels, to say now that you're not in that production mode and you want to be in a total care mode. The reimbursement systems still don't adequately address the time that you need to spend with a patient to deliver meaningful care, because it's not in a production basis. And so the Medicaid system is different from the Medicare system. The commercial insurance system is somewhat different from the governmental payer systems. And then we still have the uninsured and undercompensated care pieces.
Yeah.
With the change in commercial insurance, with the desire to have patients have skin in the game to try and gain cost containment, what we've ended up is with a block of patients that are functionally uninsured for primary care. They're insured because once their total costs hit certain thresholds, which may help specialty care cost and coverage, it may help institutionalized cost and coverage, let's say hospital admissions. But for primary care purposes, if you've got a $5,000 deductible or $6,000 family deductible,
Sure.
in essence, you're uninsured. So patients will delay care. They will scrimp on their prescriptions, which could help them. The prescription therapies could help them. And so there may be access issues there. And it just complicates the delivery system.
Short-term pressure relief, but long-term deep problems.
Absolutely.
Deep yogurt. Oh, the future. It's bright and cheery indeed, isn't it?
I'm hopeful of the future. You know, as I've seen the health centers grow over the years, and when we started, the health center programs were $200 million. And we could fit everybody in a smaller conference room, and that was all of us. And now when I look at 1,500 organizations and health centers and taking care of 28 million patients.
Yeah.
Maybe we'll hit 29 million patients this year.
Yeah.
Might be 30 million next year. We're seeing more and more of our population, patient population in this country. And I think that impact that we have, the connection that the health centers have with the patients, is important, because I think we can help them address their health status, we can help them feel better, we can improve their health outcomes. And I think Congress, and I think the nation is starting to see that health centers can provide solutions not only to uninsured access or low-income access or geographic access in the rural areas, but we're there to also address some of the nation's problems that have come up over the last couple of decades, whether it was HIV, now we're dealing with the opioid issues, and it seems like Congress is turning to health centers for solutions. And I think we're showing some really good success in dealing with very difficult patient populations. And the more we do, I think the more we'll be asked to do.
Well, that's, I think our whole history has been, as I think you've said more than once, running toward the fire. When something breaks out, it's typically health centers who are on the front lines, because these things break out in the very communities that health centers existed and serve. But instead of running away from the problem, we've run toward it to try to address as best we can and resolve these issues.
Absolutely. I think we saw that now with the opioid issues, and the fact that it was a growing crisis in the country. But health centers started working on addressing the opioid issues 4 or 5 years ago.
Yeah.
As we started to see those dependencies in some of our patient population, we started working with that block of patients to see how we can improve their care, how we can better provide patient management for patients with chronic pain, and whether we were being a part of the solution or being part of the problem. And so we had a head start because we needed to. And part of it is just our connection with our patients. Health centers are embedded in the communities, and their patients are there. We don't have distant corporate offices that have no contact with the patients we care for.
We're right there.
We're there.
On the front lines.
Front lines,
Michael
11,000 sites and growing.
Yeah. Congratulations, Mr. Chair-elect.
Thank you so much.
I feel very confident in the future of health centers with you at the helm of NAC.
Thank you, Dan. It's always a pleasure to talk to you.
All right, buddy. You take care.